Welcome everyone to week 8. This week we are discussing preoperative care and postoperative care. This lecture will focus on preoperative care and will reflect chapter 20 in your textbook. So this is where my life has been as a nurse practitioner. I was a nurse practitioner in cardiac surgery for 14 years, and so I'm very familiar with the preoperative and postoperative care of surgical patients. So why do we do surgery? Surgery is performed to diagnose, cure or repair, palliate, prevent, explore, and or provide cosmetic improvements. Oftentimes we see palliation surgery done for individuals who are cancer patients, and so to provide them some pain relief, oftentimes surgery is done for pain relief or palliation. Surgery may arise with unexpected urgency, so that's emergency surgery, or be carefully planned event, which is elective surgery. Ambulatory surgery, also called same-day surgery, is generally preferred by patients and physicians. Ambulatory surgery can be conducted in emergency departments, endoscopy clinics, doctor's offices, and outpatient surgery units in hospitals. Patients requiring hospitalization for surgery are usually admitted the day of their surgery, so same day admission. So these are your inpatients. Ambulatory surgery procedures can be performed with the use of a general, regional, or local anesthetic, usually take less than 2 hours, necessitate less than a 3 to 4 hour stay in the post-ascendant care unit, so the PACU, and do not necessitate an overnight hospital stay. So let's look at the nursing assessment of the patient before surgery. So why do we do this? Well, we do this to confirm and identify changes to patients' physical status by reviewing the physical exam, confirming preoperative consultations are complete, say for instance by a cardiologist, internal medicine, physiotherapy, or a wound care nurse, and communicate mobility or sensory deficits to the perioperative team. So the perioperative team needs to know the patient's physical status. It's done to determine the patient's psychological status and reinforce coping strategies. It's done to establish baseline data, so vital signs for comparison in the intraoperative and postoperative period, to identify prescriptions and over-the-counter drugs and herbal products, to ensure laboratory and diagnostic tests results are documented and communicated to the appropriate individuals, to support the patient's language, family, culture, and spiritual or religious needs that may affect the surgical experience, to determine whether the patient has received adequate information from the surgeon and has made an informed decision to have surgery, and that the consent form has been signed by both patient and physician. It's done to confirm that appropriate preoperative consultations with members of the healthcare team have been done, and to ensure the patient understands the discharge plan and has post-operative support. This may involve consulting with and setting up post-operative care with rehab facilities or community nursing agencies. So very, very important, the implications of the preoperative nursing assessment. So let's look at the subjective data. So psychological assessment. So excessive stress response can be magnified during the getting prepared for surgery, and this can impair the recovery. And so anxiety can impair cognition, decision-making, and coping abilities. And this may result from lack of knowledge, unrealistic expectations, and information lessens anxiety. So you need to use common language, use an interpreter if needed. It decreases the level of anxiety, identify what those stressors are. And anxiety may arise from conflict with interventions. Maybe you have religious beliefs around blood transfusions. And so you need to identify those beliefs and discuss with the surgeon and the operative staff. Some of the common fears around surgery are death or disability, and so that may prompt postponement, and it can influence the outcome for the individual. Pain and discomfort is huge, and that requires a consult with the anesthesiologist or the anesthetist or anesthesiologist about preoperative medication if fear is extreme. And you need to reassure the client that drugs will be available for pain management. Maybe clients are scared of mutilation or alteration in their body image, and so you need to assess those concerns non-judgmentally. What about anesthesia? The whole feeling of loss of control while you're being anesthetized or while you're under anesthesia. And then disruption of life functioning patterns range from fear of permanent disability to temporary loss, include family and financial concerns. And so those may be, you may need to involve different consultations when necessary, such as a social worker, a chaplain. And then to always remain cognizant to individuals' spiritual inner peace and hope, and that you need to reinforce positive coping mechanisms, never deny or minimize, and assess and support the spirituality, inner peace, and hope. In the nursing assessment, information should also be obtained concerning any problems with previous surgeries or reactions to anesthesia, as well as family health history. So familiar diseases such as conditions, cardiac or endocrine disorders, reactions or problems to anesthesia, and we're going to speak about malignant hypothermia in a few slides down the road. Current medications. So all findings of the medication history should be documented and communicated to the intraoperative and postoperative individuals involved. The nurse should specifically ask about the patient about use of herbal therapies that may cause complications during surgeries, and also recreational use, drugs, alcohol, and tobacco. Allergies. The patient with a history of any allergic responsiveness has a greater potential for demonstrating hypersensitivity reactions to drugs administered during anesthesia. And so patients should also be screened for possible latex allergies. So let's look at the nursing assessment in the subjective data. So a thorough body systems review is performed and documented before surgery by many members of the perioperative team, including the nursing team. So the nervous system. You're evaluating neurological functioning, vision or hearing loss can influence results. And so you're assessing or you're assessed or correct for any deficits before surgery if possible. If they cannot be corrected, determine whether there are appropriate resources and support to assist the client. What about if an individual is blind or cannot hear? So thinking about how you're going to support that patient after surgery. And the preoperative assessment of the older adult patient's baseline cognitive function is very crucial for intraoperative and postoperative evaluation. The cardiac system. So the purpose of evaluating the cardiovascular function is to determine the presence of pre-existing disease or existing problems so that the patient's condition can be effectively monitored during the surgical and recovery period. So, any use of cardiac medications. Do they have a pacemaker? Have they had a myocardial infarction? And so it's very important that vital signs are recorded preoperatively to have a baseline. What about during bleeding and clotting time? So you'll be doing specific blood work and other laboratory reports as required. The respiratory system. So inquire about any recent airway infections. Procedures could be canceled because of an increased risk. History of dyspnea, coughing, or hemoptysis reported to the operative team. Do they have COPD or asthma? So there's a high risk for bronchospasms, laryngospasms, hypoxemia, and atelectasis afterwards. And smoking history. Smokers should be encouraged to quit 6 weeks before the procedure to decrease the risk of complications. And the greater pack per year of smokers equals a greater risk for pulmonary complications. The urinary system. Do they have a history of urinary or renal disease? What are their renal function tests? You need to note problems with voiding and inform the operative team. Inform the client if there will be a catheter will be in place following surgery. You may need to involve the urologist to insert a Foley catheter prior to surgery. The skin system, so the integumentary system. Are there any history of skin problems? History of pressure ulcers is really important to ensure that extra padding during the procedure. because these will affect the postoperative healing. The MSK system. Report problems affecting any neck or lumbar spine issues, because that can affect intubation and airway management during anesthesia delivery. Identify joints affected with arthritis. Are there any mobility restrictions that may affect positioning and ambulation after surgery? Do they use a walker? Do they use a cane? Do they have trouble getting in and out of bed? Importance to bring mobility aids with them to surgery. And report, as I said, report problems affecting the neck or lumbar spine prior to intubation. The endocrine system is huge. The patient with diabetes mellitus is especially at risk for adverse effects of anesthesia and surgery. These patients are at risk for the development of hypoglycemia, hyperglycemia, ketosis, cardiovascular alterations, delayed wound healing, and infection. Clients with diabetes mellitus, they need to have a capillary blood glucose test the morning of surgery for a baseline. And you need to clarify with the physician or the anesthetist if their usual dose of insulin is taken or not taken. And usually there will be orders from the anesthetist of how much insulin to give the day of surgery and which oral anti-diabetic meds should be held. Other parts of the endocrine system are the clients with thyroid dysfunction. And so hyper or hypothyroid is a surgical risk due to altered metabolism rate. The immune system. Clients with a history of a compromised immune system or using any immunosuppressive drugs can have delayed wound healing and an increased risk for infection. Fluid and electrolyte status is also very important. Remember, these individuals are going to be an MPO status, and so these, if they're coming in for surgery the day of or the day before, midnight before, so it may require additional fluids and electrolytes prior to surgery if dehydration occurs. And so any vomiting, diarrhea, or difficulty swallowing can cause an imbalance. You need to identify any drugs that the patient may be on that could alter the fluid and electrolyte status, such as diuretics. You're going to be evaluating the serum electrolyte levels pre-surgery. And again, the importance of the MPO status. Obesity. Obesity stresses both the cardiac and the pulmonary system and makes access to the surgical site and anesthesia administration more difficult. Also with this obesity, individuals could have obstructive sleep apnea, and ventricular arrhythmias and hypertension are potential complications due to obesity. The nutritional status. And so again, if it's an individual with poor nutritional status, they may be very thin and weak. And so provide extra padding to underweight clients to prevent pressure ulcers. And it's important to identify any dietary habits that may affect surgery. For example, caffeine. If you're coming in for heart surgery, it's recommended that afterwards you do not have any coffee. So a caffeine-free diet. So let's look at the objective data for the nursing assessment before surgery. So the physical examination. So depending on which province and which region and which health authority and which hospital you're working in, they're going to have their own policies on preoperative health assessments. But it's very, very important that a preoperative health assessment is on the chart, and it's usually done by the family doctor or done in the pre-op clinic. And that's very important to understand, the pre-op history of the individual or of your patients in case surgical complications arise. So that's one of the mandatory things that will be in the chart prior to surgery. Laboratory and diagnostic test. And so it's determined, lab and diagnostic tests are determined on the client's history. And so it's your role to document any relevant findings and report them to the perioperative team. You will obtain and evaluate results of lab tests and monitor blood glucose for diabetics. So pre-op blood work needs, if you find anything out of whack, it needs to be, the surgeon and the anesthetist needs to be notified. So this is the pre-op blood work that typically is done. So a complete cell CBC count, complete blood count. So a hemoglobin will look at anemia. Leukocytes will look at an infection and the immune status. Hematocrit measures how much of a person's blood is made up of red blood cells, so again looks at anemia. And platelets, bleeding risk if low and a clotting risk if high. So these are the important pieces of the CBC. Your kidney and renal status and fluid status is going to be looking at electrolytes and your creatinine level. Liver and clotting factors are very important because the liver is involved in clotting. So you're going to look at liver function tests, your PT, PTT, and INR, or look at your clotting factors and your bleeding times. Blood sugar tests are very important, and all patients are typed and screened for blood, except for individuals that are Jehovah's Witness who will not be receiving blood products. What about diagnostic tests? So in the midst of COVID, all patients now are screened for COVID, but other typical diagnostic tests are chest x-rays, an ECG to check your heart rate and any pre-existing cardiac problems. MRSA and VRE swabbing is done, COVID screening, and other diagnostic tests depending on past medical history and surgery. Preoperative education is so important. So the client has a right to know what to expect and how to participate in their surgery, in their recovery of their surgery. It increases client satisfaction and it reduces fear, anxiety, stress, and it's been found to decrease the duration of hospitalization and recovery time following discharge. So it's very important. You may have limited time available to do this, and so it may end up addressing needs of highest priority. Include information focused on safety is very important, and always provide written material to clients and their families. Types of information. So preoperative teaching involves the following types of information. So sensory, so what patients will see, hear, smell, and feel during surgery. The process, so the general information about what will happen, and the procedural, so these are the more specific details. Different patients with varying cultures and backgrounds and experiences may want different types of information. And all teaching should be documented in the patient's record. And so you want to learning, and that is the importance of documenting, is that learning can be reinforced and supplemented if required. You can assess the patient's learning, and community nurses must be informed if client has ongoing learning needs. And so that's why it's really important to document it and report it to the postoperative nurses if you're doing this preoperatively. So it's important to let postoperative nurses know that this patient has no one, that they live alone. They live on a 2-level house, and going up and down the stairs might be a problem. Things like that. So general surgery information for what to expect after surgery. So all patients should receive instruction about deep breathing and coughing, using a central spirometer, coughing, and moving postoperatively. So these are for your larger surgeries. Inform the patient if tubes, drains, or monitoring devices or any other special equipment will be used postoperatively. And then ambulatory surgery information. So basic information before arrival, the time and place and registration, what to wear and bring, the fluid and food restrictions. Is there a need for bowel prep or medications? Is there a need for a preoperative shower for our cardiac surgery patients? There was a preoperative shower that they had to do. And the importance of transportation after surgery. Clients will need to have a ride home. Legal preparation for surgery is important. So these forms are signed and on the chart. Informed consent, the requirement for consent for blood transfusions. If there's any advance directives or power of attorney, these should be all on the chart. Consent for surgery. So informed consent is an active shared decision-making process between the provider and the recipient of care that allows the patient to assess information and make an informed decision. So this is the responsibility of the surgeon to ensure adequate disclosure of the procedure, risks and benefits, to ensure there's understanding and comprehension. The operative consent must be signed before any preoperative medication is given, and it's voluntarily given consent. And so informed consent is valid only if it is voluntary, The patient has the mental capacity to consent, and the patient is properly informed. And voluntary consent means that the patient must be free either to consent to or to refuse treatment without coercion, fraud, or under duress, so under stress. The surgeon is responsible for obtaining consent. The nurse may obtain and witness the signature. They can document it in the client's chart. They can verify that the client has understanding, and the client's permission may be withdrawn at any time. And if the client does withdraw their permission, it is your responsibility to inform the surgeon. Consent for surgery. So a true medical emergency may override the need to obtain consent. A capable minor. So a capable minor is a child or adolescent with an advanced level of understanding who is deemed by the physician obtaining the consent to have the intelligence, education, and experience to give informed consent for a procedure. Children and adolescents should be assessed for capability to consent on an individual basis. And in Quebec, people 14 years and older can give consent. In Ontario, I believe it's 16. Also, a legally appointed representative of family may consent if the client is a minor, unconscious, or mentally incompetent. Day of surgery. What's the role of nurse for the day of surgery? So on the day of surgery, the nurse is responsible for the final preoperative teaching, the readiness assessment to make sure the patient's ready for surgery, so lab, blood work, everything's on the chart. Communication of pertinent findings from diagnostic procedures and consults to appropriate healthcare providers, ensuring that all preoperative preparation orders have been completed, ensuring that records and reports are present and complete to accompany the patient to the OR, verifying the presence of assigned operative consent, lab data, a history and physical exam report, baseline vital signs, and your nurse's note or your documentation complete to that point. And typically there will be a pre-op checklist that you will go through and sign off. And a couple of other things, I think I've already talked about so I've talked about these already, the lab data, history and physical, baseline vital signs, nurse's note to complete. And the other important part is no cosmetics, contact lenses, nail polish, or false, so your denture is removed. So these are the important parts. Other roles of nurses is that, again, clients should not wear any cosmetics. Observation of skin color is very important in the OR. Removal of nail polish for the pulse oximeter, as I've already said. Valuables returned to the family member or locked up. Dentures, contacts, prostheses are removed. Identification and allergy bands are on the wrists. And it's important to tell the patient to void before surgery. It prevents involuntary elimination or voiding under anesthesia or urinary retention during the early postoperative recovery. And then before surgery, medication administration. So you want to make sure that they're up to the bathroom before you give any preoperative medications that would cause them to have maybe faint, syncopal, dizzy. So speaking of preoperative medications, they may include a benzodiazepine or a barbiturate for sedative and amnesic properties, anticholinergics to reduce secretions, opioids or narcotics to decrease intraoperative anesthetic requirements for pain, antiemetics to decrease postoperative nausea and vomiting, and any other additional drugs such as antacids, antibiotics, eye drops, and routine prescription drugs, which you will get an order from an anesthetist to tell you which drugs can be given prior to surgery. Transportation to the operating room. So for inpatients transported by our surgery to the operating room, side rails up and secure the chart and the preoperative equipment with the client. For outpatients transported by surgery or wheelchair or may walk to the operating room, if accompanied, you would accompany them. And the method of transport is documented by the nurse responsible for the transfer per hospital policy. Family are typically instructed to wait in the waiting area where they can be informed of the progress. Consider the cultural considerations for pain, coping, and family expectations. And you need to be aware of and supportive of cultural perceptions and beliefs of clients when preparing them for surgery. Decisions made because of cultural variations must be respected and valued. So maybe there's a certain individual, a priest that needs to be there, a rabbi needs to be there. Maybe there's a certain cultural procedure that needs to take place, a ritual that needs to take place prior to surgery. And just to end off with just some age-related considerations. So older adults have sensory, motor, and cognitive older adults may have sensory, motor, and cognitive deficits, necessitating that more time may be needed to complete preoperative testing and understand preoperative instructions. And so an event that has a little effect on a younger client may be overwhelming to the older client. There's greater risks associated with anesthesia and surgery, and there's greater risk for postoperative complications. So you need to consider the client's physiological condition, not just his or her chronological age. Consider any sensory deficits. What is your knowledge of their family support? And you need to remember this is a real threat to their independence, lifestyle, and self-esteem, and it may result in ineffective coping. So these are really important pieces to take into consideration for the older aged adult going to surgery. So next up will be postoperative care.